A very good morning to all. I, Dr. Uttara Mohan, on the behalf of IAP Digital Team, welcome you to this webinar. This webinar is being organized by IAP Women's Cell Mumbai District, Maharashtra. The speaker for today's webinar is Dr. Vincent Paramanandam. He'll be talking about introduction on lymphatic system and its link to cancer-related lymphedema and lymphedema management. We are live on IAP India YouTube channel. I request all to subscribe to this channel to get regular notification during our live webinars. You can also follow updates for our upcoming activities, online and offline activities, on social media platforms such as LinkedIn, Twitter, Instagram, and Facebook. Now I request the Mumbai team to please take over.
Good morning, everyone. I am Dr. Deepika Mehul Viras. First, I will give a short intro of IAPWC, that is IAP Women's Cell. IAP Women's Cell functions under the guidance of National Head Dr. Ruchi Varshne and IAP President Dr. Sanjeev Jha. We have 5 zones in India with heads for each. Dr. Pooja Kamble is the West Zone head. The state team of IAPWC Maharashtra includes State Coordinator Dr. Suvarna Ganve, Joint Coordinator Dr. Snehal Patel, and Sub-Coordinators Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sanghi. In Maharashtra, IAP Women's Cell has conducted many low-cost activities like CMEs, workshops, webinars, public awareness campaigns, health camps, blood donation camp in various districts since 2018. In the year 2021, 22 and 23, IAPWC Maharashtra has received award for Best IAP Women's Cell State Team. In today's webinar is on introduction of lymphatic system and lymphedema management, and it is conducted by IAPWC Mumbai District, Maharashtra. The resource person for the today's webinar is Dr. Vincent Singh Paramanandam. We welcome you, sir. As this webinar is associated with the Society of Oncophysiotherapists, the president of this society is Mrs. and Dr. Anuradha Daptardar. I'll just introduce her. Dr. Anuradha Daptardar has graduated as a physiotherapist from GS Medical College, Mumbai, 1989. She joined Tata Memorial Hospital in 1991 and has been the officer in charge of the physiotherapy department since 2010. She has about 30 years of experience in treating cancer patients. She is an internationally certified lymphedema therapist. In 2014, she received the Significant Achievement Award by Indian Association of Physiotherapy for her work in the field of oncology. She has pioneered the oncophysiotherapy for her work in the field of oncology. She founded and registered the Society of Oncophysiotherapists in India and is the president of the society. She has conducted many onco rehab workshops in Mumbai, Pune, Belgaum, Nasik, and more. She has many national and international publications to her credits. We welcome you, ma'am. Now I will request Dr. Anuradha Daptardar to give a short intro of the Society of Oncophysiotherapists and our resource person. Thank you.
Thank you, Dr. Deepika, and thank you, IAPWC, for giving us this opportunity of promoting our society. The Society of Oncophysiotherapists was registered in 2019 in India. The president of the society is Dr. Anuradha Daptardar, that is myself. The secretary of the society is Dr. Ankita Chitre. The treasurer of the society is Dr. Ajita Kulkarni. The society was basically registered with a vision and mission to promote onco-rehabilitation, cancer rehabilitation across the country, and to serve as a platform for evidence-based guidelines in the practice of onco-rehabilitation. It gives me great pleasure to welcome our resource person for today, Dr. Vincent Singh Paramanandam. Dr. Vincent has been our colleague and has worked in Tata Memorial Hospital for the last 20 years. He is currently a lecturer and researcher at the University of Sydney. His research addresses physiotherapy for the cancer sequelae, particularly lymphedema following breast cancer surgery. His recent randomized controlled trial proved that prophylactic use of compression sleeves reduces the incidence of arm swelling in women at high risk of developing breast cancer related lymphedema. This trial, which was published in the Journal of Clinical Oncology, is in the top of all research outputs scored by Altmetric and has received the Best of the Best Oral Presentation Award at the Clinical Oncology of Australia Society's scientific meeting in 2023. Dr. Vincent has also been awarded a prestigious strategist scholarship from the University of Sydney. Dr. Vincent is also the founder member of the Society of Oncophysiotherapists and is on board of the executive committee of the society. So I welcome Dr. Vincent.
Thank you, ma'am. Thanks a lot for the kind introduction. And I would like to extend my sincere thanks to the IAP Women's Cell and also the entire committee of IAP for giving me this opportunity along with the Society of Oncophysiotherapists. And you have all put in a lot of effort to make this happen. So let's move on to the presentation, and I would like to share my screen. Just bear with me. If that goes well, then it's good. Let's have a look. Which screen you're seeing? Is this the screen? Can you see my screen or no? Excuse me. Can you see my screen?
Yes, we can see.
Which screen you're looking at? Because I have multiple screens open.
We see the desktop home screen.
Okay. Supposed to be here. Let me check. You're seeing the presentation or the other one?
Yeah.
One minute. I'll just switch this, please. Bear with me.
So you can open the PowerPoint presentation, then click on share screen on Zoom, and you can select that share the PowerPoint.
Yeah, so it's not giving me the selection option. So just I'm looking at the PowerPoint. Just give me a second.
Alternatively, you can do a desktop share. So whatever application you open on the desktop will get shared to us.
Yeah. Okay. Let me have a look now if it works. Okay, share screen. Yeah, that's fine. Thanks. This again. Oh, it's done. Let me share screen. Okay. Screen one, screen two, share screen. Can you see my screen now, the presentation?
Yes. Yes,
Okay,
sir.
thank you very much. Yeah. So yeah, thank once again. Sorry for the interruptions and technical difficulties, and also I would like to thank once again to the IAP Women's Cell and also the Society of Oncophysiotherapy for giving me this opportunity. And usually the webinar or any Zoom meeting is always kind of one-way process. So I just would like to move away from that. And really, I would like you to interact with me, though virtually, because it is webinar, you will not be able to open your mic and speak to me, the audiences, and some of them are on YouTube. So you can, even from YouTube, you can interact with the presentation. Presentation means with me. So please, if you can have an extra device, for example, if you're watching in laptop, can you grab a mobile close by so that you can interact with me virtually? Okay. So let's move on to the presentation. Before we talk about the lymphatic system, I would like all of you to grab your mobile and you can, scan this QR code, or you can select that link below and start answering these three questions. You can directly type in on the screen where if you see in the right lower end, there is a plus sign, and click that sign and you can add your answers to the three questions live. Okay, so then if you are doing that, then I can go back and share the screen, and this is the screen where you will be adding your answers. And don't worry, it is totally anonymous. And if you have any issues, please put it in the chat box. And you should be able to reach to this level. So I can share the link also in the chat. Okay. So for you, so that you can get involved. So I'll give you 2-3 minutes just to do that. Did you get to the slides, Dr. Deepika? Is that possible to open the link? Yeah, that's good. Someone has entered already. Okay, that's good. Fantastic. Please add as much as possible, and there is no right or wrong answer. The link is in the webinar chat, so please, yeah. Okay, so I'm sending that to only the panelists. Sorry about that. So yeah, great. That's nice. Okay. Looks like we no need to explain much. You guys have good grasp over the topic, I think. Yeah, that's nice. It is the drainage system complementary to venous system. Okay. Elephantiasis, of course. Lymphedema, of course. Yes. To drain the lymph. Yes. Is there any other function? And you can also vote for whatever the answer you love or like. That's nice. Yes. Mm-hmm. Good. Mm-hmm. Yeah, that's nice. Mm-hmm. Lymphoria. Yeah, that's amazing. Mm-hmm. Okay. So keep doing it, and don't stop. And as you listen, you can do it. Yeah, that's nice. Body, yeah, plays role in immune system. Good. Yeah, yeah, nice. Okay. So we have quite a bit of knowledgeable people in the audience about lymphatic system and lymphedema. So with that, I'm going to move on with the presentation and keep engaging with the presentation. So when we move on to the other slides, we will open up different links. Okay. So now let's move on to the next slide. So as you can see that, lymphatic system is involved in many major diseases, especially related to cardiovascular disease, cancer, obesity, and infection. However, um, we in our curriculum, it has been neglected for a long time. So we don't learn much about lymphatic system in our physiotherapy curriculum. As a healthcare practitioner, we need to know the lymphatic system well to manage such dreadful conditions. And if you see the WHO mortality rate, these are the disease, stays in the top 4 level. So it is very important. We need to know about lymphatic system. Having said that, we will just look at what is lymphatic system. In this slide, the definition simplified. So what is lymphatic system? In simple words, the lymphatic system is a system of thin tubes and lymph nodes that run throughout our body. These tubes are called lymph vessels or lymphatic vessels. The lymph system is an important part of our immune system. Uh, that means it fight against the disease. And also, apart from this lymphatic vessels, we have some collection of lymph cells as lymph tissues, and those systems are spread all around our body. So the important system for our topic today is the lymphatic system, the vessels, and the lymph nodes that we are going to look at. Functions of lymphatic system, as you have mentioned, it maintains the volume and pressure of extracellular fluid, which means it maintains the fluid balance in our body. And also, the most of these lymph nodes are the sites of clonal production of immunocompetent lymphocytes and macrophages. Let me explain a little bit here. Clonal production means photocopying function, kind of a photocopying function. Immunocompetent lymphocytes and macrophages means the lymphocytes and macrophages which are ready to fight against the invading infections. So these cells rest in the lymph nodes, or the lymph nodes act as the storage mechanism. Whenever there is an antibody reaches, and then immediately there is a cascade of events started with that. These lymphocytes and macrophages are doubled and tripled, and they then activated to be released in the blood system so that it can fight against any invading infection. So you all probably well aware of this particular image. We are familiar with the cardiovascular system because we are probably learning this from our year 11 and 12. and also in physiotherapy, we have learned a lot about this system. As you all know, when the heart contracts, the oxygenated blood is thrown out and into the systemic circulation, and that moves all over our body. It carries the oxygenated blood. And in tissue capillaries, there is gas exchange happens, and then the deoxygenated blood then comes back to the heart when the heart relaxes. Okay, so the reverse happens in the lung when heart contracts. Deoxygenated blood goes to the lung to be oxygenated and then brought back. Okay, so in tissue capillaries, because of this high pressure created by the heart, fluid escapes from the vascular system into the extracellular space. Okay, when this fluid goes into the extracellular space, that um, increases the pressure in the extracellular space. Just to enlarge that capillary system, as you can see, this is the arteries and this is the vein. And when the fluid escapes into the extracellular space, this cannot get into the venous system. Once we believe that it goes through the vein back to the heart, but it doesn't because of the high pressure within the vein. It won't allow the fluid to get back into the vein. So most of the fluid escape like this has to get back to the blood system. It can happen only through the lymphatic system. So these are the lymphatic system, and these small, tiny finger-like structures are called the lymph capillaries or initial lymphatics. Okay, these initial lymphatics carries the fluid back. So how it does? So the initial lymphatics are having a single layer of endothelial cells which act like a valve, and part of the one endothelial cell covers the other one, and it acts like a valve. And whenever there is increased in interstitial pressure, the fluid then opens this valve and then gets into the initial capillaries. Where once the capillary pressure increases, that closes the valve, opens another semilunar valve through which it can go in only one direction towards the heart. Okay, that's how the fluid moves. So the initial lymphatics are connected to the three collector vessels, and these three collectors are connected to the lymph vessels, and it is connected to the superficial lymphatic collecting vessels. And all along, you have semilunar valves, which allows the fluid to move in only one direction, that is towards the heart. Okay, and from here, you can see these are the lymphatic channels, and it runs all over our body. And these lymphatic channels are intersected by multiple lymph nodes. And these lymph nodes are concentrated in particular areas like, the elbow, axilla, inguinal nodes, and pelvic region, and also in head and neck region. And these nodes receive the circulation or the lymph circulation from specific organs and part of the body. And most of the lymphatic circulation from our left side of the face, upper head and neck, upper trunk, and also both lower limbs drains through the left lymphatic duct. This is the left lymphatic duct, and this is the biggest duct, whereas the right lymphatic duct drains only the right head and neck region, right trunk, and right upper arm, and it drains into the subclavian vein. And both left and right lymphatic ducts drains into respective subclavian veins. That's how it reaches the heart. So the lymphatic system, unlike the heart, it is not the complete circulatory system. It is just a one-way system. So it draws fluid from the extracellular matrix and then it brings back to the heart. Okay. So I said that the lymphatic vessels are intersected by multiple lymph nodes. And this is a lymph node and of inguinal lymph node. And you can see this is the lymph node body. And these are the afferent lymphatic vessels. These are efferent lymphatic vessels. Afferent means the fluid gets into the lymph nodes through these channels. And efferent means the fluid now moving from lymph nodes towards the heart. Okay. And when we see the cross-sectional image of the lymph nodes, you can see this is the medulla or medullary region. It looks like similar to in a small kidney, and this is the medulla, and this is the germinal area. And in this germinal region, you have lymphocytes, and in the medullary region, we have macrophages. So if there is any infection comes through this, then it activates these cells, and then these cells reproduce, and then it moves into the system and fight against our infection. Okay. So now from here, we are going to another quiz or another question. So here, this is a different website altogether. So what you need to do is you have to go to www.menti, menti.com, and then it will ask you a code, and please enter this code, and then you will get into a survey. Okay. Or a questionnaire session that we can interact again. Okay, thanks. Can you see? What do you think helps the lymph flow through lymph vessels? That is the question, and you can answer by entering text. Okay. If you have any issue with reaching this space, please let me know. Alternatively, you can scan this QR code, and that will take you directly to the yeah, it will directly take you to the question. Okay, so let's have a look. Yeah, that's good. Pressure difference between vessels. Okay, muscle pumping action. Fantastic. Or changes in pressure. Yes. Pressure gradient and presence of valve. Yeah, absolutely. Valves and pressure gradient. Wow, that's someone who is from, I think, lymphedema training, hydrostatic and oncotic pressure. Fantastic. Okay, we have got only 5 answers. Come on, all of you can engage. Yes, pumping action of the muscles. Yeah, of course. Any other answer? Cells oscillations. Pressure gradients. Again, yeah, that's nice. Pressure and valves helps move the lymph in the lymph vessels. Yeah, that's nice. Any other answer? Come on, you can do better. I know all Maharashtra IAP branch is very active, and we always interact well. So I would expect more answers here. Even people from YouTube, you can scan this QR code and enter into the Menti and answer. Okay, I hope people have got saturation at this point. Yeah, now we can go to the presentation. Okay, you were correct. So spot on, pressure gradient. And only missing thing was internal pump. and which is very important. And of course, you have mentioned some external forces about muscle pump. Okay. So now let's move on to see these three different pumps that helps in a lymph flow towards our body. Okay. Pressure in lymphokinetic motion, how pressure helps. As you have all identified, blood capillaries have high pressure because of the heart pumping. And when the heart pumps, the pressure is felt throughout the capillaries. And because of high pressure, the fluid oozes into the interstitial fluid where the pressure is comparatively lower. And again, lymph capillaries pressure is lower than the interstitial fluid. So the fluid moves into the lymph capillaries when the pressure reaches to a certain level. And when it is in lymph capillaries, again, it moves to the lymphatic vein, lymph nodes, lymphatic ducts, and brachiocephalic veins, all because of the pressure gradient. And also, of course, there is this valve which helps in this fluid moving towards the heart. Next is the intrinsic pump. So this lymphatic the proximal valve, sorry, distal valve, and this is a proximal valve. And so I hope you can hear me well because there is internet connection issues message I'm hearing here. I'm looking at an internet connection issue. Is that clear?
Yes, sir.
Yeah, okay. So you can hear me still. Okay, I'll go ahead. So these, in between two valves, this section is called a lymphangium. And within this valve wall of the lymphangium, you have smooth muscles, and these muscles work like our heart muscles. So these muscles can generate its own contraction. So it contracts and it develops kind of a systolic and diastolic phase similar to heart. And in heart, there is only one pump, but we have multiple pumps all along the lymphatic channels that helps in this fluid motion. So whenever this muscle contracts, there is a systole. And when there is a systole, the pressure, because of the pressure, the fluid moves towards the proximal direction because the proximal valves open and the distal valve closes. And because it is one-way valve, the fluid moves smoothly towards the proximal area. And the how it generates its own pulses is still under research, and we know very few details, and there are many hypotheses about phosphorus pumping and different mechanism. Let us not get into that details, but it generates its own basic contraction that helps in the fluid moving proximally. Okay, it's a fascinating science. And let's move on to extrinsic pump. Apart from this intrinsic pumps, there are some extrinsic mechanism also assist in the lymph flow, as you all identified skeletal muscle contraction, because the lymphatic vessels are, going through the muscles and in between muscles. So whenever there is a contraction in the muscle, which also increases the pressure inside and opens the proximal valve, and the fluid then moves towards the heart. And another important pump is the respiratory pump. So whenever, because of these major ducts or within the thoracic cavity, when there is inspiration, it creates a negative pressure and it draws fluid from distal regions towards the thorax. And when there is expiration, which creates positive pressure, the fluid then drains into the subclavian vein, and it goes into the heart. So I hope this video gives you audio, and if there is no audio, please let me know. Okay. I'll stop here. Just, can you please let me know whether you can hear the sound?
No, sir.
Okay. So let me just have a look. Hmm, Okay. The sound should work now. Let us have a look. Okay. So if it is not, then I'll explain that.
Which have been absorbed from the GI tract and is a source and mode of transport to lymphocytes and macrophages. Lymph arrives at lymph nodes from afferent lymphatic veins and is filtered before passing into the efferent lymph veins. These vessels are extremely thin and are easily compressed when adjacent skeletal muscles contract. This produces a muscular pump, which propels the lymph forward with the help of the semilunar valves. The fats that it carries cause the lymph in the thoracic duct to be very milky in appearance and gives the name lacteals to the lymph capillaries found in the intestine. Valves consist of two opposing cusps which fill with lymph when the muscles ahead of them contract. This prevents the lymph from traveling backwards into the interstitial fluid and forces it to go forward through the open semilunar valves.
Yeah, I hope you had summary of how the lymphatic system works. And now let's move on to the connection between these lymphatic channels and lymph system and lymphedema. So as you can see here, the breast tissues are drains into the axillary lymph nodes, and which also drains the upper limb. Okay, so when there is any tumor, for staging purpose, for example, diagnosis, and also for intervention, we intervene with the lymph nodes. In staging, for example, when there is the tumor cells move onto the lymph nodes, and when we remove the lymph nodes and evaluate under microscope, we can easily see whether the tumor cells have reached the lymph nodes or it has gone beyond lymph nodes. If it is not reached to the lymph nodes, which is early stage cancer, when it is reached the lymph node, it could be called locally advanced breast cancer. And if it crosses the lymph nodes and goes beyond and settles in any other part of the body, then we consider that as metastatic cancer. So these different cancer types or stages, we will treat differently. That's why it is very important to evaluate the lymph nodes. When we need to evaluate the lymph nodes, we damage the lymph nodes. So when there is a damage in the lymph nodes, it not only affects the drainage from the breast, it also affects the drainage from the arm. So that's why it could lead to arm lymphedema. The same thing goes with any inguinal node or pelvic nodes. If we remove the nodes for staging or for treatment purpose, it can reduce the drainage from lower limb. So it leads to lower limb lymphedema. As you can see here, the treatment involves excision of all the affected lymph nodes. So if patient comes with advanced disease, then probably surgeon would remove all the nodes, or they may go for irradiating the nodes or nodal bed. That causes blockage to the lymph flow, that eventually leads to the lymph swelling. And not only breast cancer related lymphedema, we also can have in melanoma cases, they remove axillary lymph nodes if it is in the arm, And if it is in the leg, then probably the inguinal lymph nodes are removed. Gynecological cancers, most of the time, they remove pelvic nodes, and genitourinary cancers, head and neck cancers, they may remove nodes from the head and neck region. That can lead into edema of the face, neck, and also internal organs, which can be very fatal for patients if that increases in size. It can, prevent person from breathing well. So these are all the commonly seen conditions, cancer conditions that can lead into lymphedema of the respective places. Okay, so now we have seen how lymphatic system function and little bit of its anatomy, and also the connection between the lymphatic system and lymphedema. Now, let's move on to the clinical bit. That is what is very important and fun bit for physio. So how will we manage these patients? Before we move on to the management, it is very important to talk about assessment. And in clinical cases where any cancer-related lymphedema patients reaches your clinic, most often they may not require any specialized investigation, imaging investigation. We know the history, cancer history, and we know they are at risk of lymphedema. And if any other signs and symptoms of disease return or metastasis or something else, if we rule out those things, we can easily diagnose them if they have swelling as lymphedema, cancer-related lymphedema. In clinical situation, we just evaluate the tissue thickness and pitting. Pitting means if we press with our thumb for 10 seconds as hard as possible uh, at the swollen area. And if there is a pitting, and if it is soft pitting, hard pitting, that we can easily make out, and that helps us staging the disease, and also the tissue thickness that helps us staging the disease. And we have some objective measures, and these are here written. And you can see the first one is volumeter. This is water volumeter, which is at SATA, and where patient can put in their arm, and when the fluid drains out, we have markings at the side that gives us how much volume of water is displaced, and we can say that is equivalent to the arm volume. And we can compare with the unaffected side and easily make out how much is the volume difference. The second one is circumferential measure, and circumferential measure are used with simple tape, and these are any tape measure that is available for even tailoring purpose. And only condition is it should be inelastic, and you can follow a standard process that the arm should be in 90-degree flexion, the shoulder should be in 90-degree flexion and elbow extension, and mark from wrist and 10 centimeter from that wrist marking. Take circumference at these anatomical level, and you can convert that using an Excel form easily into a volume. And so comparing with the unaffected side, we can easily make out how much is the volume difference and how much is the swelling. Only for the hands, we use different circumference measure that is called the figure of eight method, because the simple circumference measure is shown to be unreliable. And one of my colleague did a study which showed that the figure of eight method is the most reliable in taking this measure. Okay. Then we have infrared Spirometry, which is a device with infrared lamps and adjacent sensor. And when the patient keeps their arm or lower limb, and if you move this frame, and it automatically takes those circumference measure, which are sent to a computer. There is a sophisticated software which can give you volume measure, circumference measure, and the difference between affected and unaffected site. And the next one is bioimpedance spectroscopy. This is the bioimpedance spectroscopy. We all might have seen or used it sometime or the other. If you have visited any of these sophisticated gyms in Mumbai or in Maharashtra, you could have used this device, which gives you the fat content, muscle mass, and things like that. This also can be used to measure intracellular and extracellular fluid content. And by taking the ratio of the affected and unaffected arm, we can then calculate the interarm impedance ratio. And if that interarm impedance ratio is more than 2 standard deviations, then we consider that as lymphedema. So the Marshall meter is similar to the bioimpedance spectroscopy device. Only thing is the Marshall meter is small, just it looks like a pen, and it can take only measurement of local tissue fluid content, whereas impedance bioimpedance measure can measure the whole body tissue levels and muscle mass and water levels. And if you see here, the only thing here, the downside, if you look at downside of all these devices, the volumeter, especially the volumeter has a cumbersome method, and we need to fill in water. The water can become contaminated and it can lead into cross infection. Water may spill, so it's a bit cumbersome to use in regular clinic. Bioimpedance spectroscopy and the infrared ferrometry are extremely expensive, even the Marshall meter. So extremely expensive, so it is not affordable in a routine clinic. Whereas the circumference, the tape measure is easily available. It may not cost more than few rupees, and you can use that if you follow a standardized, you know, protocol, you can get a reliable measure, and you can use that and convert into volume. And you can see the reliability and validity of these measures in this particular paper. And another issue with the diagnosis is threshold. In literature, if you see, different thresholds are used. Someone has used more than 2 centimeter increase in volume from baseline, that is before surgery, or increase or difference between the affected and unaffected arm as swelling. Some papers have done that, especially some of the papers from India. And some others have used volume calculation. And volume calculation that is more than 5% are used in some paper, and 10% is used in different papers. So this causes confusion, and we don't have any consensus. And again, if you look at impedance bioimpedance, some used more than 2 standard deviation, some have used more than 3 standard deviation. So these things causes confusion among people, and also some defend their choices. Whereas when you are using in clinic, it is better to use increase from baseline. So it is important to have baseline value before the surgery if you have arm circumference measure. If you don't have arm circumference measure from baseline, it is better to compare from the other limb and what is the percentage of increase from that limb. And next one is relative to the unaffected arm. So increase from baseline is not there. You use the relative difference from unaffected arm or leg. If there is a bilateral lymphedema, then you can compare it with leg. So we have some calculations and normative value to show how to calculate those things. And better use a consistent method. So always use a particular threshold so that it will be consistent in your clinic. And choosing between different tools that we have seen here. So it is better always choose one that can be affordable and you can use it for a long time. So probably you may be able to purchase bioimpedance spectroscopy, and which needs replacement electrodes often, that may be a hindrance later on. So you may not be able to use it for a long period of time. And whereas if you use circumference measure, it is much easier in our setup. We know that our setup is low resource country, so it is important to use which is affordable and reliable at the same time. And this is the volume conversion from circumference measure. The Excel is available in internet and you can download, and if you enter the circumference measure, it calculates volume for you. And also it gives you relative arm volume difference. So easily you can calculate this in your clinic. And arm circumference measure is quick. You can do it in within 5 to 10 minutes. We also use self-reported or patient-reported outcome measures, that is questionnaires. And we have many questionnaires out there in for that are lymphedema specific. However, not all of them are reliable and valid. If you get to read this paper, we published recently about the measurement properties of various questionnaires. And we found for lower limb, limb called leg, and for upper limb, lymph ICF upper limb questionnaires are reliable and valid. So we recommend these two questionnaires if you are interested in using patient-reported outcome measure to evaluate their quality of life or physical function or psychological function. Okay. So with all this information, what we can do is we can stage the disease or stage the lymphedema. And stage 0 is called subclinical, whereas patient has undergone lymph node dissection. However, they are not having any obvious swelling, but they are at risk. So you will not be able to see any volume difference between the arm, but still they are considered as subclinical stage. In stage 1, there will be some swelling, but lymph elevation and treatment often reduces the swelling. And also patient may have pitting. This is a bit considerable pitting. Just to show you, I have chosen this picture. But in stage 1, the pitting will be a bit milder than this. And in stage 2, may or may not respond to the treatment or elevation. The lymph swelling may not reduce. And also you can see fibrosis. The fibrosis is more evident. And in lymphostatic elephantiasis, or the third stage, where you can see these out of proportion and out of shape limb with lot of folds, and there may be some infections. So this is called lymphostatic elephantiasis. That is stage 3. Why we need to know the stages? Because based on this stage, we do treat them differently. And we will, when we go to management, we will see that. Yeah. So now I think we have completed the first section. If there are any questions, please put it in chat, or you can, if you have options, you can open your mic and ask me, and I'll give you a few minutes. So if there are no questions, I would invite all of you to move on to the next one. So this is about your understanding of this presentation, whatever we heard in this first section. So just I would invite you all to answer this particular question. What is one of the functions of lymphatic system? So you have four options, and you can select. Um, yeah, that's good. Mhm. Okay. So we have more than 50 people attending this webinar at least, and apart from YouTube. So I would like you to respond. Yeah. Okay. So I think at least 12 people are agreeing that um, the lymphatic system helps in maintaining the fluid balance. That's good. So you have heard the message. Okay. Now let's move on to the, that's good, 13. Okay. Next, move on to another slide. So, okay. I myself, I don't know what is this discussion. Okay, I think okay, we'll skip this one. I, I think yeah. What's the question actually? Yeah. Look at your phone and select as many as possible. Okay. Yeah. So that's great, and I think no one selected respiration and smooth muscles, I suppose. And yeah, that's the wrong answer. Intracellular mechanism. Okay, that's fantastic. And yeah, now let's just to kind of an icebreaker, and for you to have rest from hearing my blabbering talk. So, yeah, that's good. You have answered well. Let's now move on to the next part of this presentation. Uh, and so we have seen lymphatic system, how it linked to the lymphedema, and how cancer treatment or staging leads to lymphedema. Now we are moving on to look at lymphedema management, the role of imaging. Okay. So again, as usual, let's now move on to a interactive session. And here, what we are going to look at is another question. So please feel free to answer. Mhm. Okay. Okay. Some are confident, and few are not confident. But yeah, let's move on to the management and see what we can offer to these women who are at risk. And And if you see many of these women, not only with breast cancer, but also due to gynecological cancer and genitourinary cancers, they are at risk of developing lymphedema. And many of the research are done with done in breast cancer related lymphedema. However, the lower lymphedema is high in prevalence. So it is very important. We also need to um, discuss about the lower lymphedema management. So the first thing is prevention. Why we need to prevent, why we need to look at prevention is because once lymphedema is established, reversing lymphedema is a challenge and it is time consuming and patient may need to lifelong do certain things to keep it under control. Hence, preventing is important to avoid persistent lymphedema, associated tissue changes, and poor quality of life. So we need to look at how can we prevent lymphedema. From the cancer treatment point of view, surgeons, radiotherapists, and the oncologists have all now well aware of the risk of lymphedema, and they are modifying their intervention more and more towards less damaging to the lymph nodes so that they can limit the number of women having lymphedema. But what is our role in prevention? That's what we are going to look at the next few slides. So this is proposed by the lymphedema framework in 2006. And what they have proposed is that we need to be aware of potential risk factors and ability to recognize signs and symptoms of lymphedema. If we identify women or patients with or at risk of lymphedema, then we may need to screen them to see whether they have any lymphedema related symptoms or swelling related symptoms. And if they do have any symptoms, then it is good to send them over to a lymphedema clinic, a trained physiotherapist or any healthcare professional who can assess and manage the condition adequately. If they don't have any symptoms, but they are at risk, then they need to be educated about the risk factors, and also we need to document the risk factors. And so in next slide, we are going to look at what are those risk factors. And the major risk factor is the axillary lymph node dissection. So what do I mean by axillary lymph node dissection versus sentinel lymph node dissection? Let me clear this term. Axillary lymph node dissection is where more than 5 lymph nodes are removed, and many times, they remove uh, more than 10, 20 lymph nodes where they consider the disease has spread in many lymph nodes, then they may remove multiple nodes to be sure that the disease is not progressing. And when that was the common practice in the past, but when they realized the axillary lymph node dissection causes more number of arm swelling and lymphedema, they introduced this new method called the sentinel lymph node biopsy, where in which they inject a dye in the tumor bed, and it's called blue dye, and they scan it uh, where the lymph node, where the dye reaches to any lymph node. So the lymph node which drains first this blue dye, or one or two lymph nodes, they are called sentinel lymph nodes. These sentinel lymph nodes are the first one to receive the lymphatic fluid from the tumor. So if they remove that node and test it, if there is no tumor cells, then definitely there is no chance of spreading further. So they no need to remove other nodes. So they can limit the number of nodes removed. That is called sentinel lymph node biopsy. So if a person has undergone axillary lymph node dissection, for example, in breast cancer, the chances of developing lymphedema is 1 in 5, whereas if they have undergone sentinel lymph node biopsy, then 1 in 20 women develop lymphedema. And radiation therapy to the lymph nodes. Definitely, it's a side effect, and sorry, it's a high risk factor. And along with axillary lymph node dissection, it increases or multiplies the level of the incidence. And only one modifiable risk factor from the patient's point of view is high body mass index. The higher the body mass index, patient is at high risk of developing lymphedema. So obesity versus overweight patients, we have seen that obese patients develop more lymphedema, more often develop lymphedema than the obesity or normal body mass index women. And having said that, you should be aware of by now that we have different body mass index for Indian population than the Western population. So what we consider as overweight in Western population is considered as obesity in Indian population. So there is a paper by Mishra et al. Which gives you a normative body mass index for Indian population. Have a look at that. And another risk factor when there is an axillary lymph node dissection is taxane-based chemotherapy. In women, those who have undergone axillary lymph node dissection, if they receive post-operative taxane-based chemotherapy, then there is high risk for them to develop lymphedema. And brain wound complications, seroma, and recurrent infections are considered to be high risk, but the data are not very clear. Okay. So how we prevent lymphedema? The first step is patient education. In TMH, we invite all the patients, those who have undergone breast cancer surgery on the day one or day one post-operative. Then we start with this group therapy session. In that group therapy session, we give instructions regarding exercise. We make them to do exercise, some specialized exercise to increase the lymph flow, and some exercise to improve the range of motion of the shoulder. And we also provide instructions about how to care for their drain so that the drain is not dislodged when they are doing exercise, and how to measure the drain each and every day. And if there is any changes in drain, what should they do? How to approach the hospital to take care of the drain so that they don't develop much of seroma. And also we make them understand they are uh, safe, they are ready to take bath and keep them safe and clean, because we also provide this Halleck spray, and it has been sprayed. You can see there is a tiny substance. This provides the coating, and that helps them take overhead bath from day one. Okay, so that's how they are keeping themselves clean and prevent any infection. And there are some do's and don'ts we really teach during this session. Some of the don'ts are no blood pressure on the affected side arm, no injections or blood withdrawal, and any wound due to sharp objects, then they need to be really care for the wound. They should not use any home care remedies. They should approach the physician for appropriate care, and they also need to observe that if there is any uh, you know signs and symptoms of infection, then they really approach the doctor for antibiotics so that they control or contain the infection as quickly as possible. And two, of course, to protect you from all the injuries and infection. But having said that, the evidence is um, poor to support all this lifestyle modification. Example, like even airplane travel is considered to be high risk, but the evidence is low, either low or unclear, supporting these um, measures in preventing lymphedema. But it is also not supporting against them. So we don't have clear guidance, but since we don't have clear guidance and evidence, so we keep educating them to continue with these lifestyle modifications so that they are at low risk of lymphedema. So another important measure is called prospective surveillance. This method was initially proposed by Stout et al. And based on this method, patients are frequently screened for lymphedema or any other shoulder morbidities. And then if they develop any signs and symptoms of swelling, then early intervention using compression sleeve. So usually they used this bioimpedance or different groups of research that used bioimpedance spectroscopy or the infrared beta to diagnose them early. And also they used this compression sleeve immediately if they found positive diagnosis of early lymphedema. Uh, but when we looked at this, we thought, why don't we use this lymphedema or sleeves, compression sleeves, prophylactically without screening them for these early lymphedema? Because if we screen them and in between, if we didn't see them and they could have developed lymphedema, that can progress. That we have seen in some of the papers. So we did a large randomized control trial called Umbrella study in Tata Memorial Hospital, where we randomized two women into two groups. Nearly 307 women participated. We divided them into compression and control group, and both groups received group therapy session, exercise, that is usual care, and the compression group, apart from their usual care, received two compression sleeves. They were asked to wear the compression sleeves more than 8 hours a day until 3 months after completion of all their radiotherapy, chemotherapy treatment. And we reassess them at suture removal 6 months and 1 year following surgery. So this study showed that we did a survival curve analysis, and let me explain a bit about this result. And in the x-axis, in the survival curve analysis, we have time since the surgery. Okay, zero is that's when they got the first assessment and they underwent surgery, and then they were followed up. And in the y-axis, you have arm swelling free probability. So if there is any one person developing arm swelling in each of this group, so the blue line indicates the compression group, the red line indicates the control group. If there is any arm swelling detection, then this drops. The sorry, this drops. Okay. So if you see the control group dropped drastically than the compression group, and that the difference was maintained throughout that 1 year. And if we also did log rank test, which showed nearly there was some 10% reduction in arm swelling in the compression group compared to the control group. And we also did Cox regression analysis. The hazard ratio was nearly half. And for those who are not familiar with hazard ratio one means there is no difference between compression and control group. Half means the compression group was way better than the control group. So we concluded that prophylactic use of compression sleeve reduced the incidence of arm swelling, delayed the occurrence of arm swelling, and it did not negatively affect the quality of life, physical function, and breast or arm symptoms. Okay. So what we proposed was using self-screening along with prophylactic compression sleeve in this women. So we taught them how to do self-screening. This is the fitting test. And these are the arm circumference measures measured by the relatives of the women, those who are at risk. And they also noted down their symptoms. So if they notice any of the symptoms as present, and if they find any circumference difference, then they can quickly come to the clinic and get the overall lymphedema assessment done so that we can catch them quickly and intervene them effectively so that we can prevent progressive lymphedema. So we use this dual method. This dual method seems to work effectively. Whereas if we use this prospective surveillance, we may need to see them at clinic every now and then. That may involve cost and for them to travel to a specialized lymphedema clinic. So all these things hinder using prospective surveillance even in remote areas of Australia and the resource limited countries like India. So compression sleeves are much better to reduce the unswelling. And as Radha ma'am initially informed you, this paper got published in one of the top journal of clinical oncology with 44 impact factor, and also it received altmetric score of 112, which means a high score, and it has been cited in a year 70 times and downloaded more than 2,500 times. So one of the physio, paper receives such an attention is, very commendable. And I think this will lead into a practice change in breast cancer related lymphedema. So now we have looked at the prevention part. So in prevention, compression sleep and self-screening method. And now let's move on to the management part once they develop lymphedema. So I would like you to participate in this particular question. And if you are already a lymphedema therapist, please, just wait for a few minutes before you answer. Let others respond first. Wow, that's good. And now let's move on to the next slide. So you can use one or two words to enter what would you offer if a person with lymphedema visits your clinic as a treatment choice. You can enter. Again, go to menti.com, use this code if you are not already there, or I will also post the link. CDT, that's good. Lymphatic drainage. Yes. Any other response? Okay, compression stockings, exercises, compression sleep, PDT, okay, manual lymphatic drainage, compression stockings, pneumatic compression, that's good. MLD or CDT, okay. Active muscle pumping, yeah, that included in exercise, right? Lymphedema bandaging, multi-layer bandaging, yes. Lymph exercise, that's good. Compression bandage, yes. Okay. So yeah, that's good. I think that gives us the answer. Let us now move on to the next slide. Yeah. So management of lymphedema, we can classify them into three different categories of treatments. One is non-pharmacological conservative management. Another one is pharmacological management and surgical management. Pharmacological management and surgical management are in developmental phase, and except the fat reduction techniques. Most of the other surgeries are involving with plastic surgery and stunting, and they are under research. Even the pharmacological agents are under research. We don't have enough evidence to support them. And that's why the position statement of Lymphedema Network says that conservative management, that is CDT, CDT is nothing but complete decongestive therapy, is a gold standard management right now, and it is safe and effective. And also from the consensus document from International Society of Lymphology suggests that the non-surgical conservative measure is the first line of treatment. Okay, so let's now look at the CDT. What do we mean by CDT? Complete decongestive therapy, which includes skincare, medical lymphatic drainage or manual lymphatic drainage. In short, we call it as MLD. And compression therapy includes the compression sleeve, intermittent pneumatic compression, and multi-layer lymphedema bandaging. We also have exercise as a component of CDT and psychological care. Okay, let's move on to look at each one of them in short. So the first one is skincare. For skincare, we advise them to wash daily using pH neutral soap so that they don't get skin irritation. And we ask them to clean the skin fold and also dry them well. If they clean but leave the moisture, it can become a source of fungal infection. And also they need to inspect their skin often. If there is any skin changes, they need to approach the lymphedema therapist. And they are encouraged to apply emollients or antifungal powders based on the weather conditions. And emollients are nothing but moisturizer. And also we advise them to avoid any scented products that can irritate. They can always check with their skin at a small patch, and then if that suits, they can still use the scented products. Manual lymphatic drainage or medical lymphatic drainage. There are multiple schools. They teach these techniques, and I'm not going into all of them, but the first six schools, and they are called traditional manual lymphatic drainage methods. And there is the bottom one that is called fluoroscopy guided manual lymphatic drainage, which means it is based on an imaging technique, fluoroscopy, that will decide how you should or where you should drain the fluid. So this particular method suggests that the imaging will give you a superficial lymphatic channels which are patent or which are intact. And then based on that mapping, you will do your technique to drain the lymphatic fluid. So let me now take you through the basic principles of manual lymphatic drainage. We basically start with clearing main junctions like lymph nodes, basins, like head and neck region where the neck and axilla for upper limb and inguinal nodes for lower limb. And we clear the proximal area first. We drain them first, and then we move on to the distal area. So in normal swelling, we always massage from the distal area to the proximal. But here we do distal to proximal, but based on the segments, we start with a small portion of the proximal area, drain it, and then move on to the distal segments. We use skin on skin method because the initial lymphatics, if you see the cross section of initial lymphatics, which has some microfilaments which are attached to the extracellular matrix. If we use our skin, we can effectively pull this anchoring filament and we can open these initial lymphatics. So this particular massage technique is skin on skin. We use the skin movement for the same purpose, and it should be superficial and gentle. You may feel like seeing that swollen area. You might want to push all the fluid at once, but no, which is not good. And it is always said that you need to do superficial and gentle because the lymphatic system, the superficial system, that's what need the massage. So it should be gentle, superficial, right speed and repetition. However, this particular thing about the pressure is contested. Some schools think that we can give now higher pressure. The lower pressure may not work. Okay. Then this is a image that shows the fluoroscopy guided manual lymphatic drainage. This is a normal lymph and a person massaging from the distal area. And these are the lymphatic channels, and these are the lymph nodes, which are white in color because it is bright now. And you can see the video if it plays. When the therapist's hand moves here, you can see the lymphatic fluids moves as the pockets of fluid towards the axilla. This is the axilla. This is their arm. Yeah, I hope you can appreciate that the lymphatic fluid moves from the distal area to the proximal region. Okay, this is the basis for the MLD, that when you do massage, nearly it pushes the fluids proximally and increases the flow. Okay, and when it comes to a clinical trial, so there was a recent clinical trial completed and published by Dawood et al. And this is a large randomized controlled trial. They included 194 patients and they randomized them into 3 groups. And the first group received fluoroscopy guided manual lymphatic drainage. Another group received the manual lymphatic drainage that are traditional, and another group received a placebo treatment, placebo manual lymphedema treatment, and all the group received remaining components of the CDT or DLT. Otherwise, CDT is otherwise known as DLT. Don't confuse. This is CDT. So all 3 groups received CDT as a usual care, and one group received fluoroscopy guided manual lymphatic drainage, and another group received traditional manual lymphatic drainage, and another group received placebo. What was the result? No benefit of manual lymphatic drainage. So there is no additional benefit of manual lymphatic drainage over other components of DLT, whether it is fluoroscopy guided manual lymphatic drainage or traditional manual lymphatic drainage. There is no benefit. Okay, this is particularly important for physios because we learn the manual lymphatic drainage, spending a lot of time, and also we practice manual lymphatic drainage. But the evidence for supporting manual lymphatic drainage is very low. But the other components of PDT are having very good evidence. So to show you the difference between a normal lymphatic drainage, normal lymph, when you do manual lymphatic drainage, you had seen a very beautiful flow of lymphatic vessels. And here you see the affected limb where there is lymphedema is present. And as the therapist is moving their hand towards the axilla, you can see not much movement, and the whole limb is hazy, and there is no proper channel present here in the affected limb. Everywhere the fluid is oozing out into the superficial section and staying at the subcutaneous tissue level. So this is what is the evidence of radiological evidence, and also the clinical evidence supports that not much of an use with manual lymphatic drainage. So the next treatment is lymphedema bandaging. So we call it as multi-layer lymphedema bandaging, or lymphedema bandaging in short. And it is integral part of the CDT or DLT. And you can see, in any condition, you can do bandaging. Grossly swollen, altered shape, size, and skin changes, and you need support to the skin, presence of lymphoria. If there is a lymphoria means oozing out of lymphatic fluid through the skin. So the skin opens up and lymphatic fluid oozes out. We have seen with lymphoria, one sitting of bandaging stops the lymphoria completely. And also, if there is heavily thickened skin, we can use modified bandaging to soften the skin. Okay. And these are the components of uh, uh, the multi-layer bandaging. You can see there is finger or toe bandaging here, tubular bandage to protect the skin, soft synthetic wool to increase the shape and size, and dense foam. This is here dense foam, and these are the compression bandages. Okay. And how to tie bandage is the most important thing in bandaging, because what we learned in physiotherapy schools when we do the bandaging for any normal swelling, we always start from distal to proximal. That's it, and we always try to increase the pressure at the distal and reduce the pressure at the proximal manually, but which is unreliable. And there are multiple factors involved there in increasing pressure. So this is called sub-bandage pressure. If you increase the pull, that is tension, it increases the pressure. If you increase the number of layers, you can increase the pressure. And if you increase the circumference, pressure reduces because it is inversely proportional. And also the width of the bandage also. If you have narrow bandage, it increases the pressure. If you have a broad bandage, it reduces the pressure. So with that formula, we have, always follow this particular method where we use smaller bandage distally for the hand. And then as we move proximally, we take wider bandages, and also we have more number of layers bandaged in the distal area. As we progress upwards or proximally, we reduce the number of bandages. We use that cushion stuff to increase the size. So we always pad with that soft bandage to increase the size to get a conical shape. When we get a conical shape, that also helps in reducing pressure proximally, increase the pressure distally to get a distal to proximal flow. Okay. And we also use IPC, otherwise known as intermittent pneumatic compression, which is a compression machine with a sleeve with multiple compartments, each compartment attached to different pumps. And so it can mimic the compression. So different protocols are set. So you can clear the proximal area first and then distal area. This helps in reduce the therapist's work, and also it effectively reduces swelling, and also it can be used for a longer period of time, and it is good for home care. Always we fail at the maintenance phase. Initially, we treat them at clinic, we get good reduction. When they go home, they just forget some of the treatment options that they have, and they may fail to do that, and they have the return of swelling. So we always teach the self-lymphatic drainage and also the bandaging technique, though we don't rely much on the self-lymphatic drainage because we know that manual lymphatic drainage evidence is poor now. So we always teach them self-bandage, or we teach the relatives to bandage the women so that they get the bandage every night so they maintain the arm volume. Another compression method is compression garments. We have two different types of compression sleeves available. Circular knit compression sleeves are off the shelf. That means you can buy directly from pharmacy. And flat knit garments are thicker than the circular knits, However, these garments needs to be tailor-made. So we have to take measurement and stitch for patient size and shape. And these facilities are available in Mumbai and all around India. And you can easily access these garments. And we have alternatives to the bandaging technique. We have now newer technologies called wraps. These wraps can also mimic bandages, and we have seen good results in comparison with compression bandages. These can be applied by patients without therapist help, and also they can adjust the pressure using a pressure gauge coming along with the garment or the wraps. And next is exercise. Is exercise safe? What do you think? So let's move on. Again, I'll stop talking now. Let me take you to another. So what do you think? Exercise is safe or not safe? You can get on board with the same link. Yeah, safe. That's good. Okay. Yes, you guys are spot on. Again, yes, exercise is completely safe. That's we can see that initially, Dr. Mackenzie from New Zealand, he's a sports medicine doctor. He developed dragon boat teams from patients, those who had undergone breast cancer surgery. And he has shown that after the dragon boat racing, which is a very strenuous exercise, they did not develop arm swelling because before that, we believed that doing strenuous exercise may increase chances of developing arm swelling because exercise needs muscle work and muscle work leads to increased ultrafiltration, and because increased ultrafiltration then again can increase the arm swelling. However, which was not the case in the dragon boat racing. And after that, there were multiple studies who evaluated weight training, especially strengthening exercise in women those who were at risk or having had lymphedema treatment. And they evaluated the effectiveness of exercise. And one of that study was a systematic review. I reviewed these papers, those who have evaluated the exercise, strengthening exercise, and which received a Best Paper of the Year award from the Australian Journal of Physiotherapy. And this systematic review and a few other randomized control trials and other reviews shown that weight training is safe and beneficial. That's why now the guidelines have changed. So patients can do exercise without increasing the arm volume. This is the forest plot showing that the weight training favors the weight training did not increase breast cancer related lymphedema volume. So it favored the weight training than the control group, though it is touching the line of non-significance. So it is just favoring, not completely showing that it reduces arm volume. Okay. And here the incidence, again, it favors the weight training group. So there was not increased incidence in lymphedema in women those who are undergoing weight training exercise. Whereas if you see the upper limb strength, those who had undergone this weight training had significant improvement in their upper limb strength, okay, which is beneficial for these women. So it is good for them to do weight training exercise. This is just to summarize my talk. We have shown that in a week, after doing PDT, you can see this is the baseline and this is after a week of PDT. And you can see that the shape and the size has improved drastically from the 1 week of treatment. And this lady came from Pune after having had this edema for 10 years. So even in chronic stage, a properly applied CDT can have such a good result. Okay, about imaging, there were multiple imaging. Uh, they are investigating these in imaging techniques. Like lymphoscintigraphy was used for a long time. In this, a radioisotope is injected at the webs of your toes or fingers, and then patients are, wait, made to do some exercise or wait for some time, and then rescan them and see how that radioisotope reaches the lymph nodes, whether it reaches or not reaching the lymph node, or it is overflowing in the local area. And that was a gold standard once upon a time that was used to diagnose lymphedema. But in cancer-related lymphedema, its role is limited because we know they are at risk. These are used for other form of lymphedema like lymphatic filariasis or a primary lymphedema. And ultrasonography, again, it has been widely used in research now. It helps in identifying the tissue thickness, and also we can use one technique called elastography, and this elastography is useful in detecting the or differentiating stage 1 lymphedema from stage 2 lymphedema. Again, MRI and CT scan, various benefits, and there are some 4-point scale pattern is being developed, and it is also under research. Indocyanine green lymphography, we have seen few videos in this presentation, and which is not radioactive, so it is safe, and also it can show you, or you can view superficial lymphatic flow and its pathways with your bare eyes. So which is very awesome. Okay, so at present, imaging has a limited role in cancer-related lymphedema because we, based on our history and as well as our clinical presentation, we treat them. We don't use imaging for any of the outcome measures at present. Okay. And this is the website of Society of Onco-PT Physiotherapists. And you can visit this website and you will get to know more about upcoming lymphedema courses. And anyone can do this lymphedema courses and you can become a certified lymphedema therapist. And that will give you more insight and confidence in treating the patients. Okay. And that's it from my side. If there are any questions, I would be happy to take them.
Thank you so much, sir, for such an informative webinar. Yes, we have few questions to be asked.
Okay.
So I'll take up that first.
Yes.
Is there any radical treatment to treat stage 3 lymphedema?
Yes. So there is, and so that I briefly mentioned, but I didn't gone through much on that. So liposuction is used widely now after a conservative therapy trial. So usually they send them over to conservative management. We do all the bandaging and things like that, and reduce to an extent of if there are any fluid, because it is always a mixture of fluid and fatty tissues. Once we remove the fluid, and then we send them over to the plastic surgeon. And the plastic surgeons usually do this liposuction technique. And after liposuction, it is paramount that they are wearing the compression garment 24/7. So the compression garment is an integral part and which has shown tremendous results. This particular technique, liposuction, with compression garment. If you would like to know more about this, you can read Brosnan. He is the pioneer in this liposuction method. Dr. Brosnan has published a number of papers about liposuction technique. I hope that answers your question.
Next question, sir. Please explain multi-layer bandage if compression sleeves are not available.
Yes. So the now these multi-layer bandaging kits are available. So you no need to purchase separate bandages, and it comes in a kit. And if you need more information about the kit availability, you can always contact Anuradha ma'am, and she would be able to give you the address and the contact person for the kit. And the multi-layer bandages are used, and it is a completely a sophisticated technique you need to learn, and at least 5 to 6 days of practice you need to put in to become comfortable in the multi-layer bandage. So I would always encourage you to attend the workshop conducted annually by Tata Memorial Hospital, where you can learn this technique, or you can, if you are so much interested before the certification you would like to see, you can always go to Tata Memorial Hospital with the permission of Dr. Anuradha and observe bandaging technique. So explaining orally may not help you, and believe me. Thank you.
And so where can we find this kit?
Uh, Kit Avdes, Mr. Avdes usually supplies, and I can add his number on chat. So give me a second, or anyone from TMH can add the contact details, please. Yeah. So we will give you the contact details for the kit. And it is also available in TMH pharmacy, and you can, I think you can purchase, but no, in TMH you cannot purchase unless until you have the case number. So I can type in the number here, 98206, Mr. Avdesh Kumar, 93590. This is his contact details, and Mr. Avdesh. I hope the spelling of his name is right. I don't know. But yeah, that's the contact person who can provide you kits.
Okay. Thank you, sir. Next question.
Yeah.
Is surge
Yes.
Faraday stimulation in elevation effective?
So we don't have evidence so far in lymphedema. I would recommend against using such paradigm, because if you apply in a wrong way, you can lead into infection and injury. So it is advised not to use such paradigm. And I don't have any evidence using or against it, but it is wise not to use it.
Okay. And how long can we use one set of bandages?
So one set of bandages usually lasts for many months, as it is always based on how the patients are using that or washing regularly. Because if they wash the bandages, it restores itself. It goes back to its own elasticity. So it is always based on how do they maintain, but usually anywhere between 6 months to 1 year it stays.
Okay. So, as you know, there are new treatment methods, cupping, matrix rhythm. Are they effective in lymphedema management?
So far, so far under research, we don't have evidence. Clinical evidence is not there. So none of the guidelines inform about cupping or rhythm therapy so far, and I haven't seen clinical evidence. So I can't comment about it. So since we don't have evidence, we don't use it. But if you're happy to do research with the permission of your ethics committee, definitely, why not?
And so is it fine if we skip manual lymphatic drainage for the patient?
Yes. Yes.
I think that's all, sir. I think last question we'll take up is, what are the principles of management for central edema or generalized anasarca?
So central edema is managed similar to peripheral edema. Only thing is some of the structures are in a very awkward position and also they are tender. So we generally use compression and various types of compressions are available. Compression sleeves are made, ready-made compression sleeves are there. And also we make custom-made compression sleeves for central edema. And also, few bandaging techniques are available to help central edema. And in case some of the places where you cannot bandage, definitely at least use manual lymphatic drainage, even if we don't have enough evidence, which seems to help the patient.
Thank you so much, sir. Now one more question is there, but sir, I
Yes.
think they need more information on lymphedema certification course and what is
Yeah.
the fees
So
and
best person is Dr. Anuradha, Ajita, Dr. Ajita, or the secretary, Dr. Ankita. And also keep a watch on the TMH website along and the onco PT website where you can get more information about the timing, course structure, and the fees. Yeah.
Thank you so much, sir. I think we'll wind up with the session. Thank you so much for this informative webinar. Now I would request Dr. Urvi Katakia, Sub-Coordinator of Mumbai District, to proceed with the vote of thanks. Dr. Urvi.
Thank you, Dr. Deepika. On behalf of IAPWC, Mumbai District, I, Dr. Urvi Katakia, Mumbai District Sub-Coordinator, would like to propose vote of thanks to all the dignitaries out there. Thank you, Dr. Vincent Parmanand, sir, for such an informative webinar and sharing your valuable time with us. Thank you, Dr. Anuradha, ma'am, President of SOP, Dr. Ankita Chitre, ma'am, Secretary of SOP, Dr. Ajita Kulkarni, ma'am, Treasurer of SOP, for connecting with us for such an informative webinar. And we hope to be connected for even our future events. A special mention to Dr. Sanjeev Jha, sir, President of IAP, and Dr. Ruchi Vaishne, ma'am, for the National Head of IAP Women's Cell. I would also like to thank Dr. Pooja Kamble, ma'am, our zonal head. Really grateful to IAPWC Maharashtra State team, Dr. Suvarna Ganvir, ma'am, who is the Maharashtra State Coordinator for mentoring us in the best possible way, and all the state sub coordinators, including Dr. Snehal Patel, the state joint coordinator, Dr. Uttara Mohan ma'am, Dr. Priya Karande ma'am, Dr. Nirali Sanghvi ma'am, for always supporting us. I would also like to thank to all the participants here for our overwhelming response for this webinar. Also would like to thank our digital team of IAPWC. Last but not the least, I, Dr. Urvi Katakia, Mumbai District Sub-Coordinator, would like to thank my colleagues, Dr. Deepika, Mumbai District Coordinator, and Dr. Masuma, Mumbai District Sub-Coordinator, for the efforts to make this event successful. Thank you, one and all. Please do share your feedbacks about our webinar. The link for the Google form has been shared on the Zoom and YouTube chat box. Thank you, everyone.
Thank you all. Bye.